Perfect. Hi there, everyone. I hope everyone can see and hear me. My name is Trent. I am an F2 in general surgery and urology at Northampton General Hospital, but don't worry, you're at the right place. This is the Trent Medical Student Psychiatry Conference. I hope you guys all who were here yesterday had a good time and learned a lot about the various subspecialties we talked about today. Today will be sort of second half of that with the similar structure of two keynote speakers. First of all being Dr. Itai Matumbike, who is Medical Director at Northamptonshire Healthcare, who will be doing a talk about leadership. Following that, we'll have a talk from Janesh Bogra, who is previous president of both not just the Royal College of Psychiatrists, but the World Psychiatric Association and the BMA, doing a talk about culture and mental health. That'll take us up through to 10:45, and then after that, we will have a short break and pick up with a careers panel with a range of subspecialties, looking at ones that we didn't talk about yesterday, particularly forensics, eating disorders, intellectual disabilities, academic psychiatry, and medical psychotherapy. I really hope you guys will get the kind of exposure to the kind of wide range that psychiatry offers. I found when I was a medical student, you get a lot of exposure to things like general adult and old age psychiatry, but you don't necessarily get placements or much experience of the smaller subspecialties. And often people find when they get to their later careers, they find these incredibly rewarding and interesting parts of the care that psychiatry can offer, despite being perhaps slightly more esoteric or less common. I myself am I'm one of the sort of Psych Foundation fellows. I'm hopefully, fingers crossed, in a few weeks where I'm going to be going for my CT 1 year. If you guys have any questions in the chat about not just that, but also to the consultant, please do post in the chat. We'll be doing a Q&A at the end, and hopefully be able to answer your questions through the day. I hope you guys really enjoy it. I'm not going to take up too much of your time because Itai is here, and I'm sure he's got far more interesting things to say than I do. And we can kind of get started from there. Itai, if you'd like to take over, feel free to start if you're ready.
Okay. Am I sharing my screen now? Can you see my screen? Am I sharing it?
Yes.
Yeah, we can see it.
Okay. Morning, everyone. Thank you very much for inviting me. My name is Itai Matumbike. I'm a consultant forensic psychiatrist at Northamptonshire Healthcare NHS Foundation Trust. I work in a low secure unit, and I am also the medical director of the trust. So I want to talk about leadership today. It's a subject which is very close to my heart. And I just want to sort of start by, asking us to think about what leadership really is. And for me, it's not about, what title you hold or where you are, or, it's about influence for me. And I put this slide up, just to show you the sort of leader that I aspire to be. I want to be the kind of leader who is present, the kind of leader who is active and who is getting involved in the task at hand. And I just ask you to reflect. If you are interested in leadership, you have to think about what kind of leader you want to be. What defines, the great leaders is the ability to start a movement. And for me, and I haven't picked this up from a dictionary or anything like that, I've kind of conceptualized in my own mind what I think a movement is. And for me, it's an inspired cause which captures the imagination of a large group of people, and ideally it's a whole generation of people. And ideally, the movement last long after the individual has left, and long after they're dead, because of what they've managed to achieve and what they've managed to change in terms of a whole new way of looking at life. I've got a few examples there of people who I certainly draw a lot of inspiration from. And for me, it's about the legacy that they leave behind. And whenever you're thinking about, taking on a leadership role, I want you to look at, your career as a leader in that role, and sort of try and think backwards. So at the end of your tenure, whatever that leadership role is, whether it's working as a lead for medical students or junior doctors or a medical educator or whatever the case may be, I want you to think about what will happen, and when you reflect on your legacy in terms of your tenure as a leader, what was the effect of you? So before you came along, what happened? Did you have, an impact? Were you present? Did you build something? Did you enhance, a system that was already there? Did you impart your knowledge and expertise? Did you support, other people? Did you create capacity? Did you strengthen an existing way of doing things? And most importantly, how did you make people feel? How did you make the people that you led feel in terms of, the impact of your leadership? Now, if you get to the end of your tenure and you have not a lot to say about any of these things, then you have been a pretty ineffective leader. And I think the world is full of ineffective leaders who hold positions of influence and do nothing with their leadership. And I think it's important for us to just think about, what we want from our leaders, because if we decide what we want our leaders to be, we've got a better chance of becoming good leaders ourselves. So when you take on a leadership role, you need to have a plan. You need to have a vision for what you want your leadership, to be about. So at the beginning of the presentation, or at the beginning of this call, I think Nij was just commenting on my background. And this is an embodiment of, the vision that I have for the medical workforce at NHFT. So at the center of everything is the patient. So when I was thinking about this role, when I took on this role in October of 2020, I was asking myself, what do I want to do? And for me, it was about, providing or enabling the existence of outstanding patient-centered care. And I thought to myself, how do I have a medical workforce that's going to be able to do these things? And hence the petals of this flower. And all of this is about your career at NHFT as a medic blossoming. And it's all about, the different specialisms that we offer. It's all about the research opportunities. It's all about the leadership opportunities. It's all about taking care of people, because leadership is about people. And it's all about recognizing that not everyone wants to be a consultant. Some people want to be middle grade doctors, and there's a space for them. Everyone has got their own niche, and everyone has got an opportunity to become the best that they can be if you give them those opportunities. And it's early days. I'm pleased to, to say that at least some of the things, which I've set out to do are starting to bear fruit, and I'm really grateful to the doctors at NHFT for the support that they've given me in my role as their leader. I've put a few quotes in there, and I've got a quote from, well, yours truly, because for me there is the way things look, and there is the way things work. So I think we all are familiar with a peacock, which is a really beautiful bird with plumage that is just so eye-catching. But peacocks don't fly, eagles do. And if you look at this eagle, well, there's not a lot to see in terms of that plumage there. It's just brown, but the eagle soars. And what I have always felt is important for me is about the impact and the effect that I have, not how I look or how, the optics are always, people always worry about optics. How will this look? But we have to look deep in ourselves in terms of, how will it work and what will the impact be? Now, this sounds a little bit negative, but I think it's important to recognize who you are. And in order for you to be effective in your leadership, you need to get enough information from a variety of different sources about what kind of personality you are. Now, if you are all things to all people, you're well on your way to being an ineffective leader because you don't stand for something. And if you don't stand for something, when the chips are down, you will just be flaky. So you need to have, a character within yourself. And don't be scared of what you believe in, because sometimes, you're going to find that there will be so many people who are so exercised by your manner that it's unreal. If you're finding that it's most people rather than some people, then perhaps you want to review how you come across. But just be comfortable in your own skin. Just be comfortable in the fact that you are not always going to please everyone that you come across. And actually, as part of that, choose your company wisely, because you become what you surround yourself with. And one of the things which has always been quite important for me as I have developed as a leader has been the network that I've developed. And when you sit with winners, when you sit with successful people, when you sit with progressive minds, you learn a lot from them. And you need to always be thinking about your network. You need to always be thinking about what do you want out of life and what do you want to leave behind in terms of your legacy. Because when you sit with winners, the conversation is totally different. It's not about backbiting, and it's not about criticizing. It's about discussing ideas. It's about discussing progress. And that's the kind of leader that you want to be. So I want to talk because you're all sort of at the point in your careers where you're sort of trying to decide what do I want to be when I finish medical school. Where do I want to go? Where do I want to find my niche? I always say to all the consultants at NHFT that every single one of them is a leader, and every single doctor is a leader in their own right. And you can lead from the front and you can lead from the ranks. But what's important is what I said earlier, that leadership is about influence. And you can be an inspirational clinical leader at any level, from the time that you're a medical student to the time that you're a consultant, to the time that you, if you are lucky enough like myself to hold a senior role, in leadership. So there are a number of facets to being, an inspirational clinical leader. One of them is to be, that excellent clinician. Like I said before, it's about that patient-centered care. It's about being compassionate, not just with your patients and their carers, but with your colleagues as well. It's about evidence-based practice, the basic stuff about, being a clinician. It's about focusing on the outcomes, focusing on safety, always seeking to improve, and having a good time whilst you're doing it. Because if you're going to be at work for most of your life, you want to enjoy it. Be the kind of leader that is not afraid to say where that you got it wrong. And often people worry about, the egos and, how that's going to land with people when something has gone horribly wrong, or when you've taken a contentious decision and you've run with it, and then it goes completely pear-shaped. and then you're halfway through it, and you're sort of thinking this is not working. Often, if you're brave enough to say, actually, this is not working, and I got it wrong, you have got a chance of getting it right. And being knowledgeable, is a good thing, and that makes you, a good leader. But being a great leader, is knowing what your limitations are and being able to sort of embrace those and help, seek help from the people who, who are able to assist in that regard. I struggle with this one because everyone who knows me is that I like to talk, but I think it's important to listen. I've sort of used my, interest in conversation to sort of connect with a variety of different people and harness ideas from a number of stakeholders, and it's amazing what you learn. I mean, I've met about 60% of the consultants at NHFT so far. I set a target for myself to meet every single one of them within the first 6 months. I'm almost there. But one of the things that I've enjoyed about meeting people has been the amount of stuff that I've learned from them in terms of, how they do things, what they believe in, and what could actually help to realize that vision that I presented to you earlier. Build relationships with everyone, and don't be snotty as a doctor. I think the thing about doctors is that they make really good leaders because they're so clever at being able to analyze the evidence in front of them. They're trained to be patient-centered. But sometimes one of the limitations, one of the blind spots of doctors is that they can be a little bit intolerant of people who are not as smart as they are. And that can be really off-putting in terms of, not being able to take people with you. Listen to feedback about how you're carrying on. And like I said to you, don't be all things to all people. Sometimes you have to say no. Sometimes you have to stand your ground, but pick your battles when that happens. Being a leader is about not just imparting your knowledge, but also allowing great ideas to thrive, and also creating an environment where people feel appreciated. Because when people feel appreciated, they will do everything over and above. They will make sure that they give 110%. And a lot of the good leaders are really good mentors. They tend to be people who are quite inspirational and quite motivational in their manner. Seek solution. Value different points of view. You do not have a monopoly on good ideas. And always remember that. Always remember that. Even if you're, the smartest brains out there, you have to be, you have to have that humility, to sort of allow other people to express their views, encourage people to explore different ways, because your way is not necessarily, the best way. And if you find yourself commanding people to do things, and not actually giving people the latitude to kind of express some of their bright ideas, you find yourself in a bit of a in a bit of a kind of limited sort of impact. One of the big learning curves, for me, through talking to people, and I think Shahid won't mind if I embarrass him with this, but there are a couple of medical leaders at NHFT who had some really great ideas about how do we sort of build a medical workforce, and when I listened to them, some of those ideas are things which we're implementing now. For instance, a GMC sponsorship, which was one of Shahid's brainchild. And what's actually happened is that when I've gone to my boss and said, "Oh, we're doing this thing," she's gone and said, "Oh, that's amazing." I was like, "No, it's not my idea," but she still credited me for something that members of my team were able to produce and create. And so you don't always have to claim all the credit, but if you are the person who is allowing people to sort of express themselves in a way that is progressive, you're well on your way to sort of creating a really good a system of leadership. Be honest, and I've said this before. Don't try and defend your ego, because that's really off-putting. Be open and honest. And the other thing I wanted to sort of think about is think about your team. I've already mentioned this, and I gave an example of how some of the people in my team have really thrived. A good leader is confident enough in themselves, that they don't need to pull other people down. What they're always seeking to do is to enhance the performance of their team, because when your team wins, you win all the time. So the last slide I'm going to leave you with is the one about inspiring performance, because you've got to think about what are you trying to do with your leadership, and you can't do everything yourself, and you have to recognize that you are only part of a larger system, but how you influence people around you to get things done can be quite sort of telling about what kind of leadership you're trying to inculcate. So you have to be a passionate motivator. You have to be ambitious, you have to be bold, and you have to have the energy to inspire people around you to go out there and go get it. Also, you have to be the sort of leader who unlocks doors instead of pushing against them, because not everything is about conflict. Not everything is about, pushing things head on. You have to sort of think to yourself, is there another way of doing this? Am I right in this thing that I think we should be doing? Ask yourself those questions, challenge yourself. But also, more importantly, enable your colleagues to overcome challenges. So I'm going to stop there, and I'm going to leave, that kind of sort of base slide of what an inspirational clinical leader looks like and what the different facets of that are. I believe I've now got 17 minutes with which to take on any questions. I think the chair will probably lead us on that.
Thank you very much. Oh, there you go, got a bit of an echo there. First of all, incredible talk. If people do have questions, please post in the chat, and we'll go through them. I think while giving you guys a chance to type those in, I'd want to ask, as someone who's a relatively junior clinician, thinking back to when I was a student and as a foundation doctor, sometimes it can be quite daunting to engage with leadership and develop those skills. Looking back to you when you were at that stage of your career, is there anything that you recommend for people who are students or foundation doctors are going into things like SHO training, in terms of things they can do to engage with leadership and develop those skills?
You will find that the really good leaders are always keen to expand their networks with everyone, so they don't see rank. I always say to myself, you don't know where the next best thing is going to come from. So the more you talk to people, regardless of whether they're medical students or whether they're junior doctors, whether they're senior clinicians, somebody out there has always got a bright idea. So expand your network, get to know as many people as possible. And I think, don't be afraid to ask for a conversation. If you want to talk to someone who you think can actually help you develop, approach them. I'm on Twitter, and a lot of people have kind of followed me on Twitter, and when I followed them back, they've then sort of inboxed me and sort of said, "Oh, is it possible for us to have a conversation?" And then when I've had conversations with those individuals, the stuff that I've learned from them, whilst they were thinking that, oh, I'm going to learn a lot from this guy, I was actually learning from them as well. So it's quite a mutual thing.
Yeah, I definitely agree with what you're saying about serendipity and getting in touch with things. I think, to give students, examples, I'm only doing this because I happened to talk to Shahid when I was working at NHFT. This is not something that's preordained or determined. And definitely I've got an experience in psychiatry through reaching out to consultants. And I think it's very daunting as a student to feel comfortable doing that. But actually, once you get over that initial, it's just an email. It's just a direct message. And I think that's
And I've got a couple of I noticed you were saying that in the kind of determined rotations for medical students, that access to some of the smaller specialties is a bit limited, but I've actually got a couple of students who had an interest in forensic psychiatry, and one of them was actually in my ward round yesterday. So they approached Sedrat, who sort of leads undergraduate teaching, and said, "Can we do this?" And then Sedrat approached me, and I said, "Yeah, why not?" Because it's just an extra person who is in ward round, and if they're there to learn, if they've got an interest, they could be, the best, a future inspirational forensic psychiatrist. So allowing them that space to learn is important. Someone called Peter McCann has said that leadership is about influence, and we can all be leaders. And he wanted me to give an example of a medical student and how they can act as leaders. When I was at Knots, there was a program called Psych Start, which was a mentorship program. That was actually started by a medical student, who took the initiative, approached the then, medical director there, Julie Hankin, to start, this. Julie, actually encouraged, the medical student, to develop this mentorship program. They were paired with a consultant who led that program, and that was, a move which defined that medical student. He ended up becoming foundation trainee of the year at some stage, and he is an academic trainee. I don't know where he is now. I haven't spoken to Tom in a while, but it's never too early, to start your leadership journey. So if you've got an idea, if you've got something that might make an impact, if you've got something that will help to influence, how things work, get on with it. Kende has just posted in the chat that PsychStart is still going strong. So it's there's that bit that I said about, great leaders, create what are called movements, whose impact lasts long after they've left. Tom Houston is no longer a medical student, but something that he helped to develop, something that he founded, is still having an impact today.
Yeah, I think what is interesting you said about engagement. It's a lot of it. It's about being passionate and authentic. I remember NHFT when I was invited to go on to their leadership papers training, and one of the things they go on about is authenticity and being something that you're passionate about. And I think for students, a lot of the things that they can really be involved in are things like engagement with specialty psychiatry societies. I did a lot of work when I was a student on outreach and set up an event for sixth form students to come into my college and have an exposure towards medical, which still runs even though after I've left. I think those kinds of things are really good examples of where a medical student can make a lasting difference to the medical school and and to kind of the outcomes of things they are passionate and care about. I think it's about finding what you truly want to be involved with, whether or not that's a subspecialty or engaging people in psychiatry or engaging people into medicine or any kind of subset of that. I was going to say, waiting for any more questions to come through. The other thing that I've noticed about you is that you're very passionate about engaging people from Black and minority ethnic backgrounds into not just medicine, psychiatry, but also into leadership. Is there any specific advice? You know, we have a mixture of people who are international medical graduates and domestic students on this call. Are there any challenges that you have reflected on that one can you feel like discussing, or there's anything that is changing that for people who are of minority backgrounds need to think about in terms of leadership and developing those skills?
Yeah. So the first thing to say is that we still have a long way to go. I see green shoots, but we still have a long way to go in terms of tapping into the kind of vast talent that's out there amongst doctors and other clinicians of a BAME background. And I think a lot of people, find it difficult to access, the relevant coaching that will allow them to sort of realize their dreams as leaders. And sometimes, it's not the number of qualifications you have. It's not, it's about what you can do. And if you can sort of build up your CV as you go through your career, and you can demonstrate, the impact that you've had in various spaces, you will then, be a much more attractive prospect to a potential employer. So whenever I'm interviewing someone for a job, I'm more interested in what they can do. I'm more interested in, the person spec and how they fit into that and how dynamic that individual is. And often people don't have access to, the way things work in order to be able to perform better at interview, for instance. And that's where, mentors come in. I, in my own career, had quite a lot of people who mentored me. Not all of them, by the way, were from a Black and ethnic minority background. I had some, really sort of generous leaders from a Caucasian background who, saw promise in me and were quite keen to develop that. And so who you engage with, I just ask the question because you never know. I mean, I met, a chief executive who was a former medical director, and his background was not even psychiatry. He was an obstetrician. I spent 2 hours with that guy, and the things that I learned from him were just incredible. He has such clarity of thought, and sometimes, it's about that sitting with winners. Sometimes it's just about, trying to expand your network and, accessing various people, and just being bold, be brave. The worst that can happen is someone will say, oh, no, I've got no time to talk to you. But, if you don't buy a ticket, you can't win the lottery, can you?
I think that's definitely true. And it's interesting what you said about mentorship. I think if there's one thing that I can recommend to the medical students here is that psychiatry is very good at offering mentorship to medical students or junior doctors. So one thing I've definitely noticed through my career is how willing and able consultants and people in leadership positions are offering advice, support. I've never actually had a doctor in psychiatry turn around and say they're too busy to at least a phone call. It may not be you can come down for it, but it will be some level of engagement. I think that's something as a specialty leadership should be, the leaders of psychiatry should be proud of. But it's definitely something that we need to promote to our students, that that's something that's there and can give you that development and mentorship going forward. So I have a last call for any final questions for Itai coming through. Otherwise, we can release him from our glass and let him.
Oh, now there's a first. Normally I just go on and on and on and on, put people to sleep.
Yeah, stunned them
I'm
into.
actually finished like 6 minutes ahead of time. Maybe because I started 6 minutes ahead
Yeah,
of time.
you stuck perfectly to time here, which I think is that's probably something to note down in the record books for everyone involved. Any final remarks from you, Itai, or is there, are you,
No, all I can say is, thank you very much for inviting me today. It's always a pleasure to kind of share my own experience. And if anything I've said, today has, inspired someone out there to kind of, think about their, leadership ambitions. I think that can only be a positive thing. And just as I have benefited a lot from from leaders who have mentored me and coached me and got me to where I am, I'm always willing to sort of give back. So if there are people out there who, time permitting, if they want to spend a little bit of time, in forensic, if they want to shadow me for a meeting, as long as it's not a confidential meeting, and they can sort of get exposure to, what does a medical director sort of get up to in their management meetings, more than happy to do that. And there are lots of leaders in and amongst us at the moment who are always more than happy to offer themselves for that sort of thing. Super. Thank you very much.
well, thank you very much for an outstanding talk. I really hope you people are kind of given that exposure to leadership and showing that is a career that is worth going into. I think on a personal, for me as a junior doctor working at NHF, I used to work at NHFT just as you joined. That representation mattered to me as a junior doctor. Seeing both you and Shahid be that force in NHFT, it's an incredibly supportive trust to work for, and that matters. And I think that is really important for us to see that. Thank you so much for a wonderful talk. I'm going to now pass over through to Professor Dinesh Bugwa, who's doing our next half hour talk on culture and mental health. So just to introduce Professor Bugwa, can you hear me, by the way? Excellent. So he has had an incredibly illustrious career, which I'm going to just try and summarize into 3 lines just to spare us talking for half an hour. But he is currently Emeritus Professor of Mental Health and Cultural Diversity at King's College London. He was President of the Royal College of Psychiatrists between 2008 and 2011. He was subsequently President of the World Psychiatric Association between 2014 and 2017. And President of the British Medical Association between 2018 and 2019. I feel that's only scratching the surface of an incredibly long career in mental health. He has touched an incredibly wide range in the specialty. I'm trying to read through your books. I'm trying to even summarize what you're doing now, but I might let you explain, Professor Bugwa, in your own words, what is you're currently taking on. But he's going to spend the next half an hour or so talking to us about culture and mental health, which I think is an incredibly important topic in terms of how everyone's backgrounds and everyone's personalities and cultures interlink into their mental health presentation. I'm sure it's a fascinating talk. As ever, questions in the chat, we should have time to discuss things at the end. But without further ado, Professor Dinesh Bugwa, please do take the floor.
Thanks very much. Firstly, for inviting me, and secondly, for that very generous introduction. I think Marie was going to be in charge of the slides, so can we have?
That's fine. I'll just bring those up for you.
Lovely. Thanks very much. It's a particularly great pleasure because I always enjoy interacting with medical students because I learn more from you guys and gals than you do from me. For a number of reasons. I think, firstly, you have a sense of inquisitiveness that, as you grow older, you tend to lose. Next, please. But it's also, what I'm going to be talking about is culture. When I first started training in psychiatry in Leicester in 1981, before most of you were born, I remember my clinical tutor, who's a lovely, lovely, lovely person, sort of as part of the weekly supervision, and said to me that if you wanted to understand British culture, you should watch Coronation Street. Now, Coronation Street was the only soap opera at that time, and I was quite surprised that it's nothing to do with British culture for a number of reasons, and I'll come back to that. But what it taught me was that the following morning, if I was doing a memory clinic, you could ask people, did you watch Coronation Street last night? What happened? So you could check their short-term memory without doing a formal testing. And similarly, working in child psychiatry, watching Top of the Pops was a great thing those days. So, you will have different levels and different challenges. So cultural psychiatry, I got interested in for a number of reasons. I mean, firstly, because I was training in Leicester, which has a fairly significant um, South Asian origin heritage population. So people were presenting in very different ways, and quite often they were being pathologized for um, what in the local culture or the context may or may not be seen as abnormal. And the reason why we need to know about cultural psychiatry is because it's important to give culturally relevant care, whether you're a physician, a surgeon, or a psychiatrist, doesn't really matter. Next, please. And there are different definitions of cultural psychiatry from, Devereux, who was a pioneer in America, who called it primitive psychiatry, now to comparative psychiatry in the 80s, and now it's very much cultural psychiatry. Next, please. And it incorporates various disciplines. It takes in medical anthropology, cross-cultural psychology, medical sociology, social psychiatry, and minority psychiatry. And for me, I mean, I think one of the reasons when I got interested in cultural differences and similarities, I then went off and did a master's in medical sociology, and then a master's in social anthropology to try and understand what's going on. And that's what makes it so exciting, that you're bringing in different disciplines. Next, please. And it is, for a number of years, people have been interested in. And in mid 18th century, there was lots of interest in America, the migrant groups, and then sort of culture-bound syndromes as the British went, as part of the colonization process, went across the globe, learning about how different cultures saw mental illnesses. And I'll come back to the culture bound syndromes in a minute. Next, please. So it is kind of looking at indigenous healing practices and culture and personality. And then there was the international pilot study of schizophrenia and determinants of outcome of severe mental disorders, which were global studies in 22 countries. No, it was less than that. But trying to compare the contents of symptoms and the outcomes across patients. Next, please. So it is, again, I mean, I think I just want to illustrate the question of drapetomania. This was a psychiatric condition created to diagnose slaves who wanted to run away from their owners. So you can see how culture dictates what's seen as normal, abnormal, deviant, and that's what's absolutely critical in psychiatry. Next, please. So culture is conceptualized as behavior patterns and lifestyle shared by a group of people, which is unique totality of knowledge of that group, their customs, their beliefs, their values, their emotions, and life patterns. Now, why is this important? Next, please. It is important because these are learned values. You're not born with a culture, you're born into a culture. And culture teaches us how to think, how to make decisions, how children are brought up, and how the child rearing patterns occur. Next, please. And it's a common heritage or set of beliefs. It's about shared meanings. Next, please. It's applicable to whites as it is to racial and ethnic minorities. And again, one of the things that I learned fairly early on when people sort of said that only Black, Asian, minority ethnic groups have cultures, and um, as if white didn't. And one of the things that always strikes me that we assume that cultures are homogeneous. They are not. If you're talking about British culture, take London, for example. Culture of people living in Hampstead is very different from that of people living in Brixton or in Peckham or in Camberwell or um, in West Ealing. So the point really is that there are local factors that we need to bear in mind. Next, please. And it is culture which determines our identities. And I haven't got time to go into different types of identities. So people can be egocentric, people can be sociocentric, the cultures can be masculine or feminine. Cultures have um, their ways of dealing with uncertainty, avoidance, which formulate and kind of um, mold the way we think and the way we see our world. Next, please. And it's a concept which is not limited to patients. We have our own cultures. The fact that you're all medical students, you have your own culture, and culture of Nottingham Medical School is going to be very, very different from King's or from Edinburgh or Belfast. So we need to bear that in mind, that there is the culture of the institution in which we train, culture of people, and where we practice. Next, please. And it is, uh, cultures create our world view, the way we see the world. Next, please. If you take nothing else from this talk, there's kind of three things, and you can then stop listening. One is that everybody has culture, whether we are aware of it or not. Two, culture is dynamic. It changes as we change in response to culture, but in return, we also change cultures. And in the last 20 years, the impact of social media on the way we think, the way we communicate, 143 letters, tweeting, has all made a difference, because these things have become integrated in our lives, and it influences cognitive and social development. Next, please. So one of the things that you need to bear in mind when you're doing medicine is the difference between disease and illness. Disease, as the work by Leo Eisenberg, and who was an anthropologist and a psychiatrist, but also by other anthropologists and psychiatrists, the question is that disease is literally dis-ease. This is when people feel something is not right. We as doctors and as clinicians are trained to treat diseases, to look at pathology and try and deal with pathology, whereas more often than not, the impact that disease has on people's lives, it stops them from working, it stops them from having relationships, it stops them from going out, um, having some kind of financial earning, and so on and so forth. So that's when disease becomes an illness. And most patients can live with their diseases as long as they can continue to function, they continue to carry on leading as normal a life as possible. Next, please. And this is a kind of diagram by Shu, published in 1985, but is still quite relevant, because in the center of this series of concentric circles is the individual unconscious. And as you move out towards 0 and 1, you get the wider society and culture and the outer world, which becomes incredibly important, the way we interact with others. Next, please. So diseases quite often, particularly in psychiatry, are socially constructed. They're socially and culturally constructed. Idioms of distress that people present with are culturally influenced. So again, for example, if you talk to Punjabi woman who's feeling depressed or anxious, she will talk about my heart is sinking. That's an idiom of distress, which is kind of expressing what she is feeling. Now, hopefully you've all done your anatomy and you know that the heart doesn't sink unless you have diaphragmatic hernia. So it is clearly a distress like butterflies in my stomach. Now, if you try and translate it into other languages, it carries a very different meaning. Next, please. And so there is the social effects construct the way people feel, the way people express. The cultures dictate how we express our distress, where we seek help from. Next, please. And it is the reality that people live in, and these interact. So medicine has its own reality, patients have their own reality, and quite often we ignore the social reality. We just focus on the patient, on the medicine reality, because we are seeing patients in very artificial situations on the wards, in the outpatients, in the emergency rooms. And for the rest of the time, when we are not seeing them, they have a life and other people are involved in that life. Next, please. So it is those kind of ideas, how they impact upon patients and doctors and how the societies change. And I'll come back to that. Next, please. So these social words are absolutely critical in psychiatry, how people express their distress, how they understand it, where they have been before. Next, please. And one of the big challenges in Western psychiatry has been the Cartesian mind-body dualism, as if mind and body don't talk to each other. So we end up spending a lot of time, effort, and energy investigating physical symptoms when we should be focusing on mental distress. Next, please. So culture affects mental health in generating symptoms and expressing symptoms, and how symptoms are experienced and people cope with it, where people seek help from, and how do they manage. Next, please. So it is causing symptoms, affecting groups of people in specific ways, and modifying symptom presentation. Next, please. Elaborating symptoms and existing across, but maybe more common in certain cultures, and pathoreactive, that cultures modify people's beliefs and their reactions. This is the work done by Wenxing Sheng, who was a psychiatrist very much interested in cultural psychiatry, who died a few years ago. Next, please. So culture can cause symptoms. So, things like culture conflict, cultural bereavement, culture shock. Next, please. And culture affects people in certain ways. Symptom contents vary. So if you have a professor of neurology presenting with schizophrenia, he or she will present symptoms in a very different way than if you have a builder presenting with symptoms of schizophrenia. So that is their culture, which is kind of creating those patterns of reaction. Next, please. And culture molds symptoms. When I started training on the elderly older adult ward, quite a lot of people had delusions that they were experiencing mustard gas canisters from underneath their bed. And that kind of gave way to after moon landing, it became sort of CIA and aliens have landed. And then it kind of, now it is about how Facebook can read my thoughts or Twitter knows what I'm thinking or what I'm doing. Next, please. So cultures do reinforce certain symptoms. And again, one of the examples is running amok. In Malayan Peninsula, there used to be this condition that if you were fed up, you were feeling angry, you were feeling frustrated, you just kind of went around um, shouting or hitting people, but it was not seen as a psychiatric disorder till the Brits decided to make it illegal. It became a crime, and that changed the whole presentation, whole scenario. And you have these shooting incidents. Uh, that's basically people running amok, but that's not seen as running amok. So how culture has changed that. Next, please. And similarly, that we know that in cultures where children are taught to drink responsibly from a very early age, rates of alcoholism and binge drinking are very different from cultures which are sort of controlling that. Rates of suicide vary across cultures. Next, please. And there again, are sort of very different reasons. And uh, again, cultures affect beliefs, and we know from clinical practice that we hardly ever see catatonia in high-income countries, though in low-income countries it's still a common presentation of schizophrenia. Next, please. So these idioms of distress become incredibly important. And if we focus too much on them, they do not meet diagnostic criteria. And I think one of the things that you need to bear in mind is that people can uh, present with psychological or emotional symptoms. They can present with physical symptoms, or they can use metaphors, as I've already illustrated. Next, please. Ethnicity is about sort of, again, there are big challenges in these definitions, and I'm currently doing some work on looking at identity across different groups and what that means. So it can be ethnicity is belonging to a group. Next, please. And race is a particularly problematic category. It's kind of given a biological inheritance, but it is not useful as a social category. Next, please. So quite often it's used as a variable to indicate superiority, that one group deserves privileges. And it's not a new phenomenon. I mean, in 100 BC, Cicero, in a letter to Atticus, wrote, "Do not get slaves from Britain because they are stupid, lazy, and incapable of learning." Also, because Britons do not understand or like music. Now, if that's not racist, I don't know how else would you say that one whole group of individuals are being kind of written off. Next, please. So there are different kinds of racism, but I just want to highlight this missionary racism, which means that one group says, "I know what's good for you, you poor thing, you can't think for yourself." And that's something that we need to be very, very careful about. Next, please. So again, it's biologically incorrect because it postulates categorical differences, whereas they're only sort of sliding transitions. It's a social uh, reality. It's a sort of social construction. Next, please. And it is, again, I mean, I think it's about privilege. It's about domination. Next, please. I'm going to sort of skip a few. Next, please. Next. Next, please. And again, next, please. So this is important because it's about institutional racism, which is about privileges, as I said. It's maintained by legal, cultural, religious, educational, economic, political, environmental, and military institutions of society. It's about creating the other, and it allows micro identities. Each of us has a number of micro identities to do with gender, religion, sexual orientation, speciality, professional qualifications, etc. Next, please. And what that means is that we can misdiagnose conditions which are perfect responses to distress in certain cultures. We may underdiagnose certain conditions. We may focus much more on culture-bound syndromes. And some groups may not get psychotherapy, or they may get wrong doses of psychopharmacology. And again, I mean, I think from your point of view, you need to bear in mind that a lot of people, a lot of cultures see different types of medication as important. Some cultures prefer injections, others like capsules, others like tablets. Some like big tablets because they're supposed to be more powerful. Some like very small tablets because they have concentrated effort. And then colors of different tablets have different meanings. So you as a clinician need to, if patient stops taking medication, you need to find out what is it that they have done. But the impact of racism is that quite often we overprescribe medication in certain groups. Next, please. Next, please. Next. And it also creates problems for us when we are interpreting research. Because we can't understand, we just sort of blame it on their race or their culture rather than understanding the distress. The questionnaires and the assessment tools that we are using are appropriate for one ethnic cultural group, but not for another. And that's what Arthur Kleinman has described as category fallacy, that we're pushing people into categories that they don't belong. Next, please. So in order to be culturally competent, you need to be sensitive. You have to have some knowledge of the culture you're dealing with, be empathic, and have culturally appropriate interactions. But more important than all of that is your own awareness of your own culture. Next, please. And this is cultural formulation, and I'm not going to go into that because that's what American Psychiatric Association have included in DSM-5. Next, please. So in summary, cultural competence is good clinical practice, and we need to be very clear that we see each patient in the context of the patient's own culture. Next, please. So patients' beliefs about illness causation vary from supernatural, that I've got this illness because of my neighbor cast an evil eye. So in that case, the individual will go to a shaman or a religious healer. If it is natural, that's something in the environment, or medical or biological. So if you go into, it's a kind of hierarchy, whether it's an evolutionary process, as cultures evolve, more people give up supernatural causation and focus on social, psychological, or a mix thereof. Next, please. Next, please. So one of the things that we need to be aware of is the cultural transference and counter-transference that patients bring in us. Next, please. So we need to, particularly if we are doing cross-cultural research, you may need to adjust norms, both qualitative and quantitative. We may need to modify the test, and we may need to reconstitute the diagnoses. Next, please. So we need to be very aware of the issues to do with race. It creates a context for personality and development. And if the patient raises a question, then you should explore that. It is both personal, social, as well as political. So you need to be aware. Next, please. So it is, when in doubt, get third-party information. That is this behavior normal in that particular culture or not? Talk to teachers, talk to community leaders, talk to religious leaders. Understand the dynamics at personal and institutional levels. Next, please. And similarly, gender is quite important across cultures. What does being female mean? What are the gender role expectations? And how do these impact upon you as a clinician and on the patient as a female patient or a female minority patient, the role and expectations of the family and the society. Next, please. So you need to be aware of your own likes, dislikes. There are patients you would like, patients that you would not. And you need to understand why is it that certain diagnoses or certain patients or certain uh, issues that you don't like. You need to be aware of your own identity. You need to be neutral and open-minded, learn about other cultures, be aware that there are differences, but there are also similarities. Quite often we get into this habit of idealizing one culture over another. Each culture has its own strengths and weaknesses, and you need to bear that in mind. Next, please. So don't assume that all minority patients are the same. So don't be colorblind. Be very clear that it is cultural relativism that you're aiming for. Next, please. So understand your ethnic heritage, whether you're monocultural, bicultural, multicultural, what messages do you receive from each cultural group? How do you recognize your abilities, strengths, and weaknesses? Are you aware of your worldview? Next, please. Avoid stereotyping. It is used as a shortcut, but can be incredibly problematic. Next, please. So to conclude, I think we need to be aware of our own micro-identities as of that of the patient. We need to be sensitive to cultural and spiritual matters. We need to be very clear that if you're dealing with patients from other cultures, there are no universal models of psychotherapy or universal models of pharmacotherapy. So you need to involve patients, their carers and families to look into their explanatory models in trying to engage with them. Parting messages. One, always have fun whatever you're doing. If you're not having fun, change something in your job, in your life. And secondly, never grow up. So thanks once again for listening. Thanks for tuning in. Happy to take questions now, or you can email me. Be very happy to help, support in any way that I can. Thank you.
Thank you very much, Professor Booker. That was a really, really, really enlightening and interesting talk. We do have a few minutes of questions now. If anyone wants to post them in the chat, we can relay them on to Professor Booker. Just to sort of kick off while we're waiting for people to type questions in, it's really interesting what you were saying about how, as a clinician, so much of you need to be careful about not applying your own preconceptions, not applying your own cultural identities. What do you think, as when you're a student and learning, for example, your mental state examination and your history taking course in psychiatry, is the most useful thing to remember when asking those questions to a patient and to kind of avoid those kind of pitfalls?
I think the major thing is that, why a patient has come to see you now, why here, what has brought them, what their experience has been. But equally importantly, I think one of the things is that where have they been? In the sense that when you started feeling like this, what did you do? Who was the first person you saw? Who was the second person you saw? And one of the big challenges that we never explore in psychiatry is that there's rather old research, and it's from America. So the reason why I'm skeptical is because it's a very, kind of largely private healthcare system. So within that, the study showed that 70 to 90% of all illness episodes were treated in personal, folk, or social sectors because you couldn't afford to go and see a doctor. So if we bear that in mind, and the work that David Goldberg and Peter Huxley have carried out, that it's a kind of pyramid that a large number of symptoms would be treated in primary care and only a few would get to us, of which very few would get to the specialists. So I think we need to be clear that what the patient's care pathway has been. And that will tell us something about the patient and how they see their experiences, how their family sees it, and how does it sort of fit in with the culture. So if you're speaking in tongues in a church, is that a pathology? No. But quite often we forget that and say, when you, again, I mean, some of the works that we did was with Black church leaders to try and educate and work with them to educate ourselves as to what is normal and what's abnormal from their perspective. So you really need to be open-minded about it.
Excellent. There's a question here from Dr. Sri asking, where do you see culture and mental health in the coming years, and what can medical students expect in terms of changes over the next 5 to 10 years?
I think it is going to become much more important as people become much more sensitive. And part of the challenge for all of us, I mean, certainly when I started, cultural psychiatry wasn't very popular. I mean, there were people like Roland Littlewood and Maurice Lipsitch who were writing about it, and people like Suman Fernando and others who were writing about racism. But over the last 10, 15 years, it's become much more mainstream. It used to be part of social psychiatry. Now it's a discipline on its own. And I think that will continue as the world becomes more multicultural. It would become even more important. And I think one of my anxieties about global mental health is that there is an assumption that the Western models work everywhere. They don't. We need to learn from other cultures and other communities, and there are examples of fantastic practice in countries with low resources who've done innovative stuff, which we should be importing rather than telling everybody that this is the way you should be treating mental illnesses.
That's really interesting what you're saying about how I think there is an element of imperialism with Western medical treatment and our model of psychiatry, and how that will change. I'm just acutely aware of the time. I don't want to keep everyone through into their break. Are there any final questions for Professor Bugwa? I think otherwise we might have got to the end of our allocated period. First, Dr. Latif has appeared.
Just hi, Dinesh. Thank you very much.
Hi, sir.
As always. Dinesh, just a very quick one, and I'm conscious of time, can you just throw some light on the Western concept of biopsychosocial versus the Eastern concepts of biopsychosocial spiritual element of that, please?
Yeah, I think it's a sort of very important distinction. I mean, one of the challenges is that somehow, because psychiatry had a very strong influence of religion, so possession states and so on and so forth, so sort of carried on, and then there was a kind of kickback to give that all up, and kind of go down the route that psychiatry is a scientific specialty. I mean, I think medicine is an art backed by science, so to pretend it otherwise is a problem. So in order to understand the patient's experiences, the whole person, you need to understand. I mean, not everybody is spiritual, not everybody is religious, but for people who are, it is important that that's incorporated. And that's, again, the point that you were just making about distinction between West and the East. Ayurveda, the Chinese system, the Greek system, they do not make a distinction between mind and body. So we need to learn from that. And we need to sort of incorporate that sort of mind affects body, affects mind, and spirituality and other factors affect both. So very happy to answer questions on one-to-one. Just email me. And if anybody's kind of also interested in writing or having things published or doing some kind of research, do get in touch. Be very happy to find things for you to do.
Excellent. Thank you very much, Professor Bugwa. I think everyone, it's been noted today about how willing and welcoming every psychiatrist who comes to these events, how as a specialty we are very good engaging junior colleagues and medical students and people going forward. So it's really grateful for your talk and your willingness to engage with the future of our specialty. So thank you very much. I think we're going to take a very short break, which will take us through to 11. And then we can pick off after that with our subspecialty careers panel, in which we have 5 subspecialties: forensics, eating disorders, intellectual disabilities, academic psychiatry, and medical psychotherapy. I was just thinking, why we just got, feel free to take away for those who need to take off. There's one question that did just come through here. There's an Argentinian medical doctor here who was talking about how starting here this was truly inspiring. How do you feel we can decolonize psychiatry and medical education?
I am relying on your generation because our generation has failed on that one. No, I think it is. You have to take the historical bits into account, and you have to make sure that the lessons we learn from history are absolutely critical, that we don't kind of wipe off that, all history is bad or all history is good. So what are the positives and what are the negatives and what are the wonderful things that are going on in Argentina? I know you guys have a very strong psychoanalytic roots, and that's, goes back to the Second World War and post-Freudian. And so what are the lessons that we can learn in developing services and designing and delivering services here? So I think it's absolutely critical that we learn from each other. And one of the big lessons for me in cultural psychiatry is that, look at examples of good practice wherever you go, and you'll find them. And that's the only way you're going to sort of decolonize psychiatry, when, we go with an open mind.
I think that's very well summarizing an incredibly complex topic into one sentence. Thank you very much again, Professor Bugwa.
Thank you.
So we will kick off in about 8 minutes time, everyone. And I said questions that can be emailed through, please feel free to put them in the chat. I think we will, Maria, if we want to put our holding slide up. Perfect. See you guys at 11 o'clock. All right, welcome back, everyone. I hope everyone managed to grab a quick coffee and got to stretch their legs, as I know these Teams events can be slightly draining in that sense. Welcome to the second half of today's webinar, focusing on a careers panel for the various psychiatric subspecialties which I haven't had a chance to discuss yet. I'm really lucky to be joined by several consultants of various subspecialties. So Dr. Santosh Madholkar, forgive me for any mispronunciations of names here, guys, who is a consultant forensic psychiatrist. Dr. Carolyn Nyman, who is an eating disorder specialist. Dr. Niraj Singh of intellectual disabilities, who is hiding behind his avatar there. Professor Scott White, I hope I'm saying that correctly, who's an academic psychiatrist, and then we'll be joined by Dr. Nicola Phillips, who's going to talk about medical psychotherapy. Now, I thought I'll best leave, the discussion each specialty to the specialist here. How it's going to work is they're going to give you guys all a few minutes to, free reign over discussion, which will allow us plenty of time for Q&As from our audience. Please do post in the chat as we go along. If that's easier, we will pick them all up and make sure they get answered. We have a fair bit of time for this. So just going off basically in the order that I've had it printed in front of me, we'll get started with Dr. Santosh Madholkar, who is a consultant forensic psychiatrist at Rampton High Secure, and also a clinical teaching fellow at the University of Nottingham. I'll leave all the other introduction for him because I'm sure he's got far more interesting things to say. So, Santosh, please do continue.
Thanks a lot. Firstly, thanks a lot for inviting me. I hope you're able to hear me. I've been working in forensic psychiatry now for the last 20 years. I trained in London. I did my core training and higher training in psychiatry in London, and been working in forensic secure services for the last 20 years. The word forensic arose from the word forum, really. The specialty of mental health, the specialty of forensic psychiatry deals with the interface between mental health and law. So as a psychiatrist working at this interface, you are dealing on a regular basis with criminal justice system, including police, probation, prison, and courts. I stumbled into forensic psychiatry by chance. During the last SHO training post on Charing Cross rotation, I was told that, see, if you want to be a consultant in London, you need to do forensic at some stage. And I've been in forensic since then, really. The thing which interested me was attending a psychiatric court divergence scheme in central London, where you actually saw firsthand mentally disordered offenders and how they present within the criminal justice system. By then, I already had quite a sound grounding in general adult psychiatry, and my interest in phenomenology, culture, neuroscience, all that added to further developing an interest in forensic aspects of psychiatry, really. So I'll just give you a brief outline of the specialty. See, most forensic psychiatrists work in secure units, and you'd have heard about high, medium, and low secure units. I work in one of the 3 high secure hospitals in the country in Nottinghamshire, but have worked across all levels of security and also in community forensic teams, which have a focus on managing complex cases within the community. And at the moment, I've just finished a clinic in one of the prisons and joining you from there, and managed to get online 7 times. So I think that is quite good. Now, in prisons, you deal with a variety of offenders, which including acquisitive, violent, sexual offenses. The role of forensic psychiatrists, there's a tension between treating a patient, but also protecting the public. So I think those are the normal tensions in day-to-day work. We deal with risk assessments on a regular basis. And one is supposed to have good understanding of mental health law, particularly Part 3 of the Mental Health Act 1983. The work is quite interesting, busy, challenging, and it also is helpful if you have a curious mind, you're able to have a reflective thinking, enjoy working in teams, and under pressure. And one of the other things which I was told when I started forensic was that you should be willing to travel and have a valid driving license. But nowadays, with MS Teams, I think that has all changed. But I think it's still an important asset to have, to be able to drive, because you are expected to travel to do all these assessments in different parts of the country. You're mostly dealing with a very underprivileged population, most of them who've been turned down by services or by other services, and you need to have a better understanding of human rights and mental health law as well. And you do get trained to be an expert witness and prepare medical legal reports for courts, either at the magistrate's court or the Crown Court and at mental health review tribunals. So it's an interesting specialty. I think as far as it could get from liaison psychiatry, I think, but the liaison here is more with the criminal justice system. I'm going to stop there, and later I'm happy to be involved in discussions. Thanks a lot. Thank you.
Thank you very much, Santosh, for your time and explaining about the basics of forensics. I think what we can do is let the questions flow in, because I think everyone needs a bit of time to get going. So we've got to start talking about eating disorders with Dr. Naeem, if that's all right, and then we can go back to you, because I think there'll be a lot of general questions that will come through, but I think we need to give everyone a moment to get going. So Dr. Naeem, do you want to kick off with?
Hi, everyone.
We can.
Can you all hear me? Hello?
Yes, we can hear you.
Oh, brilliant. I'm Kaz Naeem. I work in the Child and Adolescent Eating Disorder Service in Nottingham. And again, you know, it's a really exciting field to be working in. It's quite new, and I think it's only recently that we've really started understanding the unique needs of this population of patients. I quite enjoy the medical side of things, and I guess eating disorders is where medicine meets psychiatry. So we're working very closely with physicians, gastroenterologists, pediatricians, and I guess eating disorders affect both physical and mental health. And the management is managing both physical and mental health risks. I think the joy of working in eating disorders is actually helping patients recover and helping them have a good quality of life. But also they are a really interesting and brilliant population to work with. So I guess those skills and interests in psychotherapy is really important, building a therapeutic relationship, working collaboratively with the patient, but also working collaboratively with physical health services as well. And we have close contact with GPs and physicians and pediatricians. It is an illness with the highest mortality rate of any psychiatric illness, but with good treatment, it really does make a difference. And the astounding changes you see with reversal of starvation is absolutely brilliant. It's a field in its infancy, and there's a lot we don't know. Our treatments are still not brilliant, but they're wonderful research opportunities as well. So if research is something you're interested in, this is a great field to go into. And yeah, I guess that because these illnesses, they are slightly longer term than others, you really do get to know patients, you get to know their families, you get to know their hobbies and interests, you need to get to know their motivations for recovery. And I think that itself is just really rewarding too. And I don't know, I get beautiful cards, paintings, thank you notes from the young people I've worked with. I don't do the job to do that, but I think there's something about having the time to build that sort of relationship with one's patients. Be prepared to travel into physical hospitals. You need to know your physiology, how to interpret blood tests. But I think that's really, really good fun and makes my life more interesting. Again, any questions really welcomed. And I guess next person can talk.
Thank you very much, Dr. Naiman. I think there was one question that we can throw out to both you and Dr. Maldholker. Both of you deal with specialties where you have patients who have particularly long admissions and with relatively low turnover. How does that feel in terms of managing patients as opposed to something like acute general adult, which is a higher throughput specialty where there's you don't get to know your patients as well?
Do you want me to answer it? Dr. Naiman, do you want to answer?
I suppose we could both chip in, but do you want to go first?
Yeah. Okay. Well, see, I think one thing we all learn when we start psychiatry is that you have to be patient and because the problems, most of the patients who got severe and enduring mental illnesses, so you have to look at the short term, medium term and long term in terms of goals and focus of treatment. And I think it is no different to some other medical specialties as well. But then within that specialism, then there is rapid turnover, like in prison, for example. If you are working in a remand prison, there is a rapid turnover of cases. You see acute presentations, and also if you are working as part of a community forensic team, things are no 2 days are the same, and you learn to deal with that uncertainty. While if you're working in a secure setting, then you can hone down and focus on complex cases, complex issues, complex presentation, and refine your skills. So I think you need to have a combination of both, really being able to think prioritize what is important or urgent, and then look at also the long-term issues. And it's still really quite interesting and rewarding area to work in.
And I guess similarly, we have to think about the life-threatening risks, the really important ones, the things that interfere with therapy and the therapeutic progress, and then everything else. But the work is very much about the relationships that you build, and not just, I guess, holding, it can be quite tricky, sort of holding boundaries against the illness. And capacity in mental health at law doesn't lend itself ideally to eating disorders, but still maintaining that therapeutic relationship and still being open and honest. And it is a challenge, and it requires really good communication skills and taking time to communicate, taking time to get to know the person in front of you and the whole person. And you do get to know them, their families, their deeper motivations. But it's also about being able to separate the person from the illness. And I think that personal connection is really important and motivating for recovery, but it's also being aware of our own stuff. So that self-reflection is really, really important. Thinking about our own role in relationships, our own communication, the impact it might have on other people. And I think this patient group, I mean, there's evidence that it is linked to, I guess, higher IQ, more autism spectrum traits. It is also something which is neuroprogressive, and you're trying to pull apart how starvation is affecting that person and what the person might be like in the absence of starvation. So it does keep you on your toes, and there's no real one size fits all. There's no sort of magic formula. And I guess that's what's exciting, is that it never gets dull. So if I think of something like surgery, or, you know, something that's sort of extreme opposite, it must get really procedural and really dull. Whereas we've got protocols for refeeding and we've got protocols for blood monitoring, but actually there are no protocols for the assessments and the risk assessments and the way you work with individuals. So there's never a dull day. And just for the students, I came to psychiatry quite late. I dabbled around, I did a PhD in biochemistry. I worked as a lecturer in physiology for a while. I dabbled in internal medicine and GP. That's okay, because by the time I got to this job, I knew it was what I really wanted to do, and I haven't regretted it at all.
Thank you very much for a really detailed answers from you both to those questions. I think what we'll do is keep moving forward to give us a chance to build, give everyone a chance to build and have a think about the various subspecialties. So I think if Niraj Singh here, who is a consultant intellectual disability, wants to crack on, that'll be perfect. And there he is.
Thanks, Chen. I'm just going to put my slides up. Can everyone see that? Are they coming up?
Yep, they're showing.
Perfect. That's great. Thanks, Chen, and welcome everybody. It's been a great couple of half days, and I hope you've enjoyed it as much as I have. I hope it's all hopefully whet your appetite as well to seek further information about what we do as psychiatrists. So I'm Niraj Singh. I'm a consultant intellectual disability psychiatrist. Intellectual disability in old money refers to learning disabilities and mental retardation, which is what it used to previously be called. So there's a lot of pejorative statements and terms that have been used to diagnose this condition in the past as well. So is that second slide coming up?
Yes.
It is, yeah. So how did I get here? Well, actually, you know what? When I was doing medicine, I really toyed, and I guess a lot of you are going through this at the moment. What am I going to do? I went through, shall I do surgery? Shall I do medicine? Shall I do pediatrics? Pretty much everything, really. Even medical law. And I found myself on a stroke ward talking to stroke patients who had depression and anxiety, which is a concomitant disorder with stroke. And I spent a lot of time with them, and I thought, you know what? Actually, I'm really enjoying this kind of time I'm spending with them and finding out more. And that led me into psychiatry and meeting other like-minded people who had also kind of inspired me to pursue this career as well. So I look after people with intellectual disabilities and neurodevelopmental disabilities. Does anybody know what neurodevelopmental disability is? It's in the slide. So neurodevelopmental disability refers to all these conditions that are up here: autism, ADHD, Tourette syndrome, OCD, and FAS. Does anybody know what FAS is? You can stick it in the chat. Anything going up in the chat? Well, FAS refers to fetal alcohol syndrome, which is the biggest cause of learning disability in Western society now. Does anybody know what historically it used to be, or what it might be in the developed countries right now? Well, it's malnutrition. Yeah, so we have it's just a growing population of people with intellectual disabilities who are also growing older in age. So we're seeing a lot of comorbid mental disorders associated with this. And some of those are listed there. People with learning disabilities at a higher risk of developing mental disorders, more so than people in the general population. And these mental disorders are listed over there. So anxiety, depression, schizophrenia, personality disorder, and bipolar disorder. And as we are seeing a growing and aging population, we're seeing a lot more people with dementia as well. And one of the great things about this specialty as well is that we see a lot of people with physical comorbidities. I want to say the great thing is that it's a real opportunity to keep on top of the understanding about physical health. And people with learning disabilities have higher rates of cardiorespiratory disorders, endocrinological problems, neurological problems, the whole gamut of stuff. So we have to work in close liaison with acute hospitals and GPs to help support this population who not just have increased risk of mental disorders, but also physical health problems as well. And you might see on this slide as well that though it's noted as a disability, we have to very much focus not just on what is the problem, but what are the actual abilities? How can we foster independence for this group of patients? And we don't work in silos. I've always said, and people would have heard the saying, the whole is greater than the sum of the parts. And we have many professionals, working alongside us. We don't work in, unison. We have to work together. And this is one of the great things about this specialty, but actually psychiatry as a whole. Is that we work alongside other colleagues. And you may have heard listening to Itai this morning, that, as a team, we have to bring together all our skills to work in the best interest for the patient. And we can't work solely independently and expect, necessarily the best outcome for the patient. So we have to have a team, which may involve nurses, psychology colleagues, speech and language therapy colleagues, who will focus on communication aspects of things, occupational therapy, who will look at activities, also may do assessment of motor and processing skills as well, physiotherapy, to help with mobility, etc. But we also work with providers, so the people and the homes who are actually supporting these vulnerable individuals as well as other voluntary agencies as well. And some of you many maybe would have heard of MenCap, which is probably one of the more prominent ones. So in terms of where we work, that's the other great things. There's such a variety of areas. I personally work in the community, so I support many people in residential and supported living environments, as well as their own home as well. I have worked in inpatient units to support individuals who have had to be admitted because they've had mental deterioration. And I've also worked in forensic mental health and secure units, and provided in-reach work in prisons where there is actually, a quite substantial population of people who come within the kind of borderline learning disability or learning disability category. And when I say learning disability, it is the same as intellectual disabilities. The confusing thing is that learning disabilities in the States, North America, is what's called a learning difficulty over here. So a learning difficulty over here is what we refer to as specific learning problems such as dyslexia or trouble with mathematics, etc., etc. So we have our team, but we also have other services that we have to work closely with. Does anybody know a condition that people with learning disabilities are more likely to suffer with, which is why we may be liaising closely with people in neurologists? Let's see if there's anything in the chat. Okay, so epilepsy. So we see a lot of our patients have epilepsy because of the brain injury. They're at increased risk of developing that condition. So we see a lot of that. Colleagues are also experienced in that, but we're not experts. Some people have done higher qualifications in the area and actually become more experts at it. But we do tend to manage sort of basic problems that might arise. But we do work in close liaison with our neurology colleagues in order to help assist if, for example, somebody might have unstable epilepsy. Also genetics. So we'll be also working with colleagues in genetics. There's a lot of syndromal associations of people with learning disability. And you will have all heard of Down syndrome, other conditions such as Fragile X, Lesch-Nyhan, Williams. There's a whole range of them, and I think we're still discovering more of them, to be honest. We also work closely with neuropsychiatry at times. Santosh was talking about forensic services. So we do also have specialist forensic intellectual disability services as well. We may also be contacted by people within the criminal justice service and be involved in the whole pathway of our particular patient. Also schools as well, for those that particularly might be doing child and adolescent mental health, intellectual disability. Social services, because it's very important often that the right environment for the patient has been identified. So we have to work in close collaboration with social services to help support them. Yeah, and it brings me on to a particular issue that I think is very important, because medicine is often thought about as assessment, diagnosis, management, and we have that particular framework which we work with. Yeah, medicine is also really about understanding what is the wider impact of the system on that individual that might be sort of compounding their illness. And in intellectual disabilities, for example, the environment's really important, and people might need an increased level of support, and families can often struggle. So a few weeks ago, I had a patient whose family was really struggling, and they needed extra support, and there was kind of quite a bit of resistance at the time from social services. So as a consultant, you can articulate what can be a clinic, what is the important clinical reason for that person to have that increased level of support. That person managed to receive that. It took away a lot of pressure from the family, really sort of stopped even their own illnesses, accelerating as well. So it's important to understand that medicine is not just about the individual, but also the wider system, and no more so than realise this in this specialty. And as I said before, we have to work with the providers and other voluntary agencies as well. So why intellectual disability psychiatry? Well, it's an incredibly diverse career. No day is the same. And to be honest with you, all of these things will apply to psychiatry as a whole. It's just not intellectual disability psychiatry. So it's applicable to all my colleagues' disciplines as well. Strong emphasis on multidisciplinary team working. Yeah, so like I said, the whole is greater than the sum of the parts, working all together, learning all the time. It's also a growing field, it's expanding. More research and things is being developed. One important reason for me as well is that you have the opportunity to make a real positive difference to a marginalized group of people. Often there are health inequalities, and we've come a long way in terms of supporting the individuals with ID. However, there is still stigma, and there is still a lot of work to be done to ensure that people get the right support within the physical health, acute hospitals, etc., because of their increased rate of physical comorbidities as well. The other thing is keeping on top of physical health management. So understanding why a person might be mentally ill, because it might not be mutually exclusive. They could also be having a physical health problem as well. So, for example, had a person who had been very anxious, very agitated, and was hitting out a lot at his family. And it turns out that his vision was deteriorating. He had Down syndrome and he had bilateral cataracts developing. And simply because he wasn't getting that sensory information, he was getting more agitated and upset and aggressive. And all needed was an ophthalmology examination, and then to get the operation, which he had. And from there, things settled. So simple thing, but actually, there's often a lot of detective work that's involved in supporting these people with ID. And that's what makes it a really fascinating career as well, is because you're absolutely trying to find out what might be the drivers to this person's presentation at this time. Whether it's the physical side, the social side, psychological, all sorts of reasons. The other great thing is, and again, like I said, it's applicable to all of psychiatry, is that you have the opportunity to meet and work with lots of great people. It just attracts really good people. And this particular organization, this 2-day, half-day conference for yourselves, we're working alongside specialty trainees, core trainees, and it's just a real joy to be able to work as a team together with people and learn, and mutually learning really along the way, not just with medics, but other allied health professionals as well. And I'm not going to shy away from this, because often medicine and money don't really go hand in hand, and it often gets that kind of we can't talk about money and things, and that's just something we shouldn't be doing. But for some, it's it's an important thing, and though I don't get much time to do it very much anymore, there are opportunities for private practice and do not just medico-legal work, but other opportunities to build up your private practice as well. And one important thing is that demands for skills will only grow. It will only expand as we have a growing population with ID who need more support. So what next? So if you're interested in getting more information, what I'd urge you to do is go onto the Royal College of Psychiatrists Faculty of ID website. Become a student associate of the RCE Psych as well. I think colleagues had already mentioned about the Psych Start initiative in University of Nottingham, and there's opportunities for you to have mentors through the Nottinghamshire Healthcare NHS Trust. There's also the Psych Star through the college, where bursary is provided and you can get access to conferences as well. Join your local Psych SOC. I believe pretty much every university has got a Psych SOC now, so it'd be definitely worthwhile, connecting with those and just finding out what they do. And I know they do have, they invite guests along as well, and I've been invited to speak in the next few weeks on intellectual disabilities. So that's definitely worthwhile to connect with. We're also running a neurodevelopmental specialty day, shameless plug. So this will be in September of this year, so watch this space. And also take the opportunity to just come along and join and do some shadowing and do some taster days if you want to find out more. Like I said, we're a friendly brunch, very, very approachable. So if you want to have, seek any further information or just find out a bit more about what we do, do get in touch. And there's just a few email addresses. Diane's my secretary, so you can get in touch with her. You can get in touch with myself directly. And Deval and Peter are consultant colleagues also working in Nottinghamshire Healthcare, who also have medical students shadowing them as well at times. So feel free to come along, find out more. Wish you all well, and do encourage you to look into psychiatry as a career. The best decision you made.
Thank you very much. That was a really thorough talk. That was really thorough talk and gave us a really broad grounding to what is a specialty, which is not always very, very well known or understood. I mean, even when I was starting as a foundation doctor, I wasn't quite 100% sure as to what intellectual disabilities covered. I think looking at the time, I think we'll keep, if there's not any questions, so we'll keep going, and then we can have sort of a chance for general questions to all of you, because I think they'll give everyone a bit of a chance to have a think about what they would ask. Also, I think you kind of covered every base possible in terms of intellectual disability. So I'd like to introduce Professor Scott White, if I'm saying that correctly.
Yeah, well done. Yeah, good.
Who is a honorary consultant psychiatrist in Sheffield in the North Recovery team, as well as Professor of Mental Health, talking about career and academic research. So I'll let you take over and go from there if we can.
Yeah, fantastic. Thank you, Chen. So as you say, my name is Scott White. I'm a general adult psychiatrist as well as a professor of psychiatry as well. So fantastic opportunity to speak to people about this and hopefully kind of enthuse people about the opportunities available. And I think it goes without saying, I think all of the speakers would agree, psychiatry is just the most amazing career. And I've been a psychiatrist since the late 1980s, and I never regretted a day of it, really. It's just the most fantastically interesting and diverse specialty. Opportunity to train, to see patients of all sorts of different types of problems, to work in fantastic teams, the sorts of things all my colleagues have said. But I want to sort of really make the point, I think that my colleagues have also been sort of emphasizing, but Dr. Norman put really perfectly, what you want to choose is a career that will never get dull, and we're all different and we're all interested in different things, but that's really the essence of what you need to think about. What really excites you, what motivates you, what do you find fascinating? Because one of the things that's absolutely certain as you go forward in your medical careers is you're going to be doing things, you're going to be practicing medicine, you're going to be training and then becoming consultants, and you'll be working for a really long time. People at my generation, maybe our generation, in working in the mental health field, were allowed to retire, many of them at the age of 55. the retirement age for your cohort is, a good 10 years after that. You're going to be doing this for a really long time. So think of things that are going to be interesting, but also think of things that are going to allow you to sustain your interest, and having a balance and a portfolio of things that you find fascinating and want to be involved in. And the reason I mention that is academic psychiatry, really, if we think about this as sort of research and teaching, go alongside your clinical specialty careers. It's unlike the things that my colleagues have been talking about. You don't choose to become an academic psychiatrist as opposed to an intellectual disability or an eating disorders psychiatrist. You do it alongside your chosen clinical specialty. And so the point being really that you're a psychiatrist first, and you have to really take your time and be, really learn to learn about the specialty, to learn about and from your patients before you develop your research interests, because your research needs to be motivated by things that you think are clinically and professionally the most important and rewarding. And we're all sort of disclosing a little bit about our kind of careers and our professional choices. Well, I started training at the Maudsley Hospital in 1988. And I was sure that I wanted to do psychiatry. I'd done an intercalated degree in social sciences, and I was really interested in people's kind of social lives and the factors that kind of, cause people to experience mental health problems. And I have been fascinated by that ever since. And when I went to the Maudsley, I didn't want to do research. I wanted to, meet patients, learn from patients, spend time talking to patients and helping people to get better. And, again, you have these kind of critical conversations with senior colleagues who say, look, if you don't do research, you won't get promoted, you won't be able to progress. You won't become what they used to call in the old money. You won't become a senior registrar if you haven't done research. So you better do some research because we expect it of you. And actually, I started doing some research in a very small way. And, you find things that are absolutely kind of addictive and that you love. And I really absolutely love this idea of finding out things, of doing things that, you could work alongside other people, because you need to learn how to do research. But actually the things that you want to research can be the things that you find most interesting and fascinating. And it's pursuing your own ideas. A lot of people, I suspect, go into psychiatry because, I don't know, but I suspect we're not very good sort of at being told what to do. And the idea, the opportunity to sort of be able to explore and to do things where you develop and pursue your own ideas was a kind of an addiction that I've never really kind of lost, actually. And that sense of autonomy, I think is there. And that's what research allows you. It comes at a price. It comes at a price that there are no guarantees. There are no secure options. You're only as good as your last study. You're only as good as your last paper. You're only as good as the grant application that you're working on at the moment. So there is that kind of anxiety and uncertainty, but it's stimulating and challenging. And you get to find out things. You get to read and learn. You get to produce research outputs, and there's nothing more exciting, I would say. Well, some people would argue, but it's fantastically exciting to see a paper and your name on it as an author, something that didn't exist before you wrote it, and that other people will be able to see and read and hopefully sort of benefit from. And that sense of kind of creating something that's kind of lasting and is original is again, fantastic, particularly early in your career. Research goes alongside every single clinical specialty. So there's no need to sort of say, I want to do research, so I'm going to be limited in the specialties that I can choose from. And every single specialty has its own need for sort of evidence and needs and questions that need to be sort of answered, because we're constantly across all of our clinical specialties trying to make sure that we provide the very best care for our patients. And the more we know about their lives and we know about the things that affect them and the ways that they recover, the more questions we have that we absolutely sort of need to answer. And that's where research comes in. And some people, of course, also, have an interest in some training through previous degrees in basic science, in laboratory science and, discovery science. And neuroscience is a fantastically kind of stimulating area of psychiatric research. And that can be combined with a clinical career as well. I think in research, as well as finding out fascinating things. Having the opportunity when you see things and you wonder if we couldn't do better, to find out better ways of providing care. It's fantastic. You get to meet work with fascinating people. You get to go places. I mean, there's no doubt that you get to travel further afield, both kind of mentally, you know, because you have to kind of know what's going on and finding out about what's being discovered in your field everywhere in the world. But you get to go to conferences and you get to go to research meetings and you get opportunities to sort of have these sort of diverse experiences. I think as academic psychiatrists, you know, and I continue to be a fully committed clinician, you know, it does bring a kind of a different perspective to your practice, you know, because we are constantly thinking about evidence and we're constantly sort of questioning and we're constantly sort of interrogating things. I think it does help hone and improve and make use of our critical appraisal skills. So I think being a researcher and being a sort of academic brings that as well. I guess what I would say is how, you know, the important thing is thinking about how you get involved, you know, in research. And what I want to suggest to you and what to put to you is that academic psychiatry is a sort of spectrum. You know, there are people who, like me, are clinical academics, and I have a joint post. So I'm employed in a university and I have a contract with the NHS and I have a foot in 2 camps and I work in both places, and that's fantastic. And I have appraisal of both parts of my job. But actually, further down the sort of spectrum, there are people who work only in one organization, only work in the NHS, but have protected research time. And then there are people who are practicing clinicians who have a research interest, who contribute to research, who help to recruit patients into studies, who help sometimes work alongside researchers who have a research interest without necessarily having kind of dedicated academic time or being formally clinical academics. If you are interested, and you know, you have to start somewhere. If you are interested in seeing how far you want to go down this pathway, how far along this spectrum you might want to find yourself, you have to start somewhere. And I think those conversations with research active colleagues are the beginning point. So in everybody's trust, you will have an R&D department. And the R&D department are fantastic. They'll be running all kinds of studies in your trusts, you know, involving patients, involving clinicians. If you go and speak to people in the R&D department, you'll have interesting conversations about the research and the work that they do. They will also provide you with opportunities to, I mean, if you've done research before and to collate a degree, you know, you might have your own ideas, but if not, and you want to sort of taster, they'll find ways for you to get involved in a sort of hands-on way with ongoing research projects. They also have links to academics, and they will facilitate an introduction to somebody who might have a research interest that aligns to your own, and having conversations and talking and thinking and reading, but conversations with people who do research, finding yourself through that, finding yourself an academic mentor, somebody who is an academic, who is a researcher, who will help you to know what opportunities there are, what pathways there are for sort of more formal academic training or appointments, and who will brainstorm and have interesting conversations with you about, you know, the research ideas that are most of interest to you. You can't, there's no substitute for those conversations. And those conversations will, if they go in the right way, will make you think more and raise even more questions that you want to go and read and find out more about. And ultimately, you know, you'll find ways to get involved, both in ongoing research projects and or developing small projects of your own. If that goes well, you know, you might want to think about academic training pathways. And those are well known, but they start with the academic foundation program and they go into the academic clinical fellowship program and ultimately through to funded clinical lectureships that are all funded by the National Institute of Health Research. And they allow people through a competitive process to have some protected time as they're training to develop those academic skills. But that's not the only way to become an academic. That's not the only, there are many, many, many different ways, very collateral pathways if you're interested enough, but it takes a lot of motivation and drive and a reaching out to people to have those conversations to then find ways to sort of tailoring your interests with opportunities. That's mostly what I was going to say. You'll have noticed that I've mentioned research, and I haven't said anything about teaching. Academics do teach, but I would be lying to you if I said that you can build an academic career as a medical educationalist. Sadly, and it's a real tragedy, sadly, teaching is not as well recognized or rewarded as research. So if you are thinking about an academic career, yes, you'll have more than ample opportunities to teach. Some people are really good at that, and there are posts that can be sort of found through that. But an academic career will really primarily be built on doing research, and an interest in research is the starting point. The gateway to a more formal academic career, when you have developed your research interest, is finding a way to take a break from your training to do a PhD. And then once you've done a PhD, then other opportunities kind of open up for more kind of substantive joint clinical and academic appointments. But I think you've got to find out where you want to be on that sort of pathway, but there's space for everyone. And coming back to what I said at the beginning, having a research interest alongside your clinical interest will make your career, many times more interesting and sustainable, because you can't be just a consultant doing clinics and ward rounds for sort of 40 odd years. It's just not possible. Okay, that's where I'm going to finish. I hope that's been helpful, and I think we're going to do a bit of Q&A later on, so I'm still here. Thanks. Okay, so
Hi, Trent. Sorry, I think you're having connection problems. Scott's just finished his talk.
I've just finished, yeah.
Yeah, sorry.
So it's Nikki next up.
Thank you very much. Got that really enlightening talk. I think what we'll do is, I think just so everyone's clear, there's a bit of an issue with the chat. So if you want to ask questions, feel free to raise your hands, and I'll keep an eye on the delegate list and try and pick them out, or you can email them through to trent@rcpsych.ac.uk. So that's TERENT@rcpsych.ac.uk, and we'll get your questions across. Or you try and raise your hands in the participant on the thing, and we should be trying to get to your questions. What we'll do is we'll go through our last speaker so we can round everyone off. Then we'll have the whole panel here to be able to answer everyone's questions and go from there. So I'd like to introduce Dr. Phillips, who is a medical psychotherapist and also training program director of medical psychotherapy higher training in the Trent region. You here?
Can you see me?
I can hear you.
Oh,
I can see you now.
I've got my camera on. Can you see me now? Or?
Yeah, there we go.
So I have a little presentation because I'm a bit camera shy, if it's okay. Put my presentation on. I don't know if this is going to work, but we'll see. I've got to try and share it. Okay. Can you see that?
Yeah, that's all working. See in
here. Okay. I'll try and do the slideshow. Can you see that okay?
Yeah, we can. Yeah.
Okay. So, hi everybody. As mentioned, I'm Nikki Phillips. I currently work as a consultant medical psychotherapist based in Nottingham, and I want to talk to you a bit about medical psychotherapy, the training, and why I think it's such a great thing to be doing. So, first off, I just wanted to mention a bit about the training route. So, because I'm very old, when I was doing my training, I had to there wasn't a dual training in general adult psychiatry and medical psychotherapy. So I had to do a single CCT in psychotherapy, and then I went on to do a second CCT in general adult psychiatry. But now you can do 5 years of dual higher training and combine it. There are lots of combinations you combine medical psychotherapy with now, but often it's general adult psychiatry, forensic psychiatry, but there are more areas developing So I worked for a few years doing a bit of both, medical psychotherapy and working as a consultant general adult psychiatrist in a community mental health team, but now I just work in medical psychotherapy. So as part of the higher training in medical psychotherapy, you major in one modality of therapy. So I majored in psychodynamic therapy, but you can do cognitive behavioral therapy as well. And through my training, I got experience in other modalities as well. So in cognitive behavioral therapy and systemic therapy. By the way, we're quite a rare breed, sadly. We could do with more training posts. We could do with more consultant posts. There are quite a few training posts in London, and I think there is actually a drive now to address that balance and get a bit more of a balance nationally. So what does my role as a consultant medical psychotherapist involve? So I currently work in a Step 4 psychotherapy service in Nottingham. I work alongside many other psychotherapists who are from diverse professional backgrounds, and they've then gone on to do training in psychotherapy. So a lot of my role is in assessing patients for actual psychotherapy. We work with patients with complexity and risk. They have various diagnoses, including developmental trauma, depressive disorders, anxiety disorders, eating disorders, personality disorders, medically unexplained symptoms or conversion disorders, and they might have a complex mix of physical and mental health problems. So I also provide psychotherapy to these patients when I've assessed them if I think they're appropriate for therapy. So I provide individual psychodynamic therapy and group psychodynamic therapy. I also have quite a prominent consultation liaison role in the Trust. So this focuses on me offering to see patients to provide formulations, particularly in cases that are quite risky and complex, and also at times to help teams manage these complex patients, because often there are the complex dynamics within the team, and this interacting with the dynamics in the patient can create some difficulties. So I feel quite passionate about integrating my thinking in psychodynamic work into general psychiatric practice where I can, and helping people make sense of team and organisational dynamics. So I have quite a prominent role as acting as a bridge between the biological and psychological. I caught the end of Professor Bugra's talk actually, and he was talking about the importance of the whole person. And I think in my area of work, working with trauma, I quite often see that disconnect in the patient between their mind and body. And also that disconnect can sometimes, unfortunately, be reflected in how services are provided at the moment. I think, we now recognise that we shouldn't be working in silos, and we should be collaborating more and working in a more integrated way across different services. So my other roles are a psychotherapy tutor for core trainees. So all core trainees in psychiatry see a long psychotherapy case. Often that's psychodynamic model that's used. And they also see a short therapy case, which is often cognitive behavioral therapy. So I supervise a lot of trainees. I also facilitate multiple Balint groups. You may have heard of these. So I run Balint groups for med students, GP and foundation trainees, core trainees and consultants. So if you haven't heard of it, a Balint group is really focusing on understanding the psychological aspects of the doctor-patient relationship and what can be really challenging, both for ourselves and ensuring we develop reflective practice, that we think about how patients make us feel so that we don't impinge on our patients' care in a negative way. I also have a teaching role and quite a prominent leadership and management role in the Step 4 service, doing service development projects, auditing, making sure there's good clinical governance. Some medical psychotherapists aren't based in Step 4 services, so now there are quite a lot of posts in personality disorder services and some in forensic services as well. I don't know how much you know about psychodynamic psychotherapy. I don't want to go too much into it today because we haven't got much time, but as part of our training, we do our medical training, but also we're advised to do an external training in our area of interest. So you might want to become a Freudian therapist or a Kleinian therapist. We work very much with the unconscious, which is what differentiates us from perhaps other therapy modalities. So we're often looking at making sense of our psychological defenses, which can be both mature and quite primitive. And we all have those. They can impact on all of us. What's different about this psychotherapy is that we're often trying to understand the unconscious in the context of dreams. And we may even use our own dreams to help us make sense of our patients. So I do remember, on one occasion having a dream about my patient, and bizarrely, my patient had also had a dream. And you could see how those dreams were both kind of interconnected. And understanding my dream helped me make sense of what was going on with my patient. So there can even be an unconscious communication between the therapist and the patient, which helps us make sense of what's going on for the patient. But essentially, what we're looking at is how relating difficulties get repeated. So early relating difficulties unconsciously get repeated through our life. And in this model of therapy, we use the relationship between the therapist and the patient in a live way to make sense of those relationship difficulties. And we pick up whether repeating patterns. So in the room, when there's a difficult situation with the patient, you'd be curious with the patient and thinking about, well, what's going on here seems to be also going on in your relationships out there now. And actually, isn't that what we were talking about when you were talking about your parents in your childhood? We use these kind of interpretations to enable unconscious hidden feelings to come into conscious awareness, which in turn can lead to behavioural change. So all psychotherapy is essentially equally effective, but it's the match between the patient and the therapist that's really important. We often work with the concept of containment in my line of work. A psychotherapist called Beyond talked about containment and how the therapist does for the patient a bit like what a mother does for an infant. So if you imagine a crying, screaming baby that hasn't developed its own thinking apparatus yet, it's completely reliant on mother to help it regulate that affect. And the mother needs to take into herself something of that infant's despair and unbearable feelings, but not feel panic, not be knocked off balance by it, to be able to hold on to her ability to reflect and think, and to be able to give back that feeling in a more manageable form in how the mother cares for the baby. So Beyond talked about how in some of our work, we are doing some of that for our patients as well. Just to say, psychotherapy is not just about the mind. Increasingly, there is more evidence that when we offer therapy, it leads to changes in the actual brain. If you're interested in understanding the biological constructs of psychodynamic processes, Alan Shaw is a really good person to look up. He did a lot of work on affect regulation, emotional attachment, and the role of the right brain. He spoke about the right brain really representing our unconscious mind and the importance of right brain to right brain communication between the mother and the infant, and also the therapist and the patient. So why did I go into this area of work? I think quite early on when I did my psychiatric placement as a med student, I was clear I wanted to go into psychiatry, but I had no idea that I wanted to go into this subspecialty. And really, it was when I did my long case as a core trainee that I became really extremely fascinated in it. It's about getting to know the person behind the condition. Of course, understanding diagnoses can be important as well. But in this line of work, patients tell you things they don't tell the closest people even in their life. They talk about their innermost fears, fantasies, and therefore it's kind of a huge responsibility doing this type of work. But I think what really appeals to me is it's about the relationship between me and the patient. That's the tool to help affect change. And I find that, you know, really challenging, but so satisfying and rewarding, really. It helps you understand your colleagues, your organisation, your team, and it can help you understand yourself. So as part of my training, I had to have 5 years of my own therapy. You're in this line of work, you're part detective, I would say. I know that's word's been used quite a lot from the different speakers, and I think maybe that's a thread running through our talks today. But I think I am part detective. It's a bit like, well, it's very different, but I see it as a bit similar to doing like a keyhole surgery of the mind. So it's peeling back the layers of the mind to help you make sense of the unconscious and the hidden feelings underneath. And it's also a very creative subspecialty to go into. So I just mentioned about trying to make sense of my dreams, of my patients' dreams. And also when I'm with a patient, I'm also very aware of where does my mind go? Where are my associations? Where does my fantasy go? And how does that help me make sense of what's going on for the patient in front of me? You're allowing the patient really to use your mind and body to make sense of their difficulties. And for that reason, it can be a very challenging specialty too, hence why the need for personal therapy. Also, just to add at the end, we know that use of metaphor can light up most parts of the brain, and often metaphor is what we're using in my line of work. So it's incredibly stimulating. And I would just add to what other people have said, that I've really enjoyed being a psychiatrist. I'm really enjoying being a psychotherapist. And I very much enjoy kind of integrating the two where I can. So I think that's the end for me. I've got to try and...
Thank you very much. So thank you very much, Dr. Phillips, for that really interesting talk in terms of medical psychotherapy, which is, I think, a specialty which is not hugely well understood. And you are a rare breed, and it's definitely something that's really interesting and broad component of psychiatry. There's a question really for the whole panel to kind of engage with, is what can students start doing now to build their experience and application if they're interested in your particular subspecialty? If anyone wants to have a crack at that one to start with.
Shall I take that, Trent?
Yeah, okay.
Oh.
Go first.
You want to go first? You go first.
So I have special interest days that students can come and join for a day or so. It is part of the rotation, and the only brilliant thing about COVID is I now get a student for a week rather than for a day. And what we found is that the patients need to get to know our medical students, see them around, beat them at double before they really are willing to start talking and divulge the innermost secrets. But some of those special interest placements, last summer we had one planned, and unfortunately due to COVID, I think our she got removed to start foundation trainee early. So, you know, by all means contact, come to the ward, meet the young people. Psych Start, I've got some trainees. We had a group planned which we've not been able to deliver yet, but you're welcome to contact me.
Perfect. I think generally with specialties, it is about getting in touch and getting experience. Speaking of someone who's a junior trainee I have an interest in both child adolescent and forensics. Even though I necessarily didn't have scheduled placements in it at medical school, consultants are always willing to take, even if it was just for a day or for a week, or there is time, and things like special study modules and components of your curriculum. I know COVID has made that harder for a lot of students, but that will make, as things start to open up again, particularly those who are slightly more junior in the medical school and have a bit more time to play with, that will open up. In the foundation program, there are 10 days set aside full trainees in F1 and F2 for taster weeks, which is protected time, which you're paid to go and enjoy a specialty, and your current job can't touch you. And I recommend that, even if you're you're going to go into psychiatry, that you use that time to explore those subspecialties. There's a question for Dr. Phillips in the chat, who says, how can students go about observing CBT or psychotherapy sessions, since a lot of patients aren't very willing to necessarily have students in with them?
Yes, that's a good question. So it might be a bit easier in CBT than in psychodynamic work. So we wouldn't tend to have students in on the actual psychotherapy sessions when we're doing psychodynamic work. But what I do offer, what I've been doing in Nottingham is I run the Ballant groups for medical students. And when I've had particularly interested medical students, they've come and sat in on a supervision group that I run. So the supervision group I run for core trainees. So that way they get to hear about the long case, the clinical work that's done. So we go in detail through the actual therapy session that the core trainee has had with the patient. And so that way we give them a bit of a taste of what a session might be like. So I don't know where the student is based, but we have psychotherapy tutors in different parts of the region. And, they're very approachable. So if you are very keen, I'm sure you could get in touch with me and I could put you in touch with them. And I'm sure there's ways we can find for you to observe, like I've just been saying.
Sure. We have a hand up. I think that's Santosh. Do you want to?
Yeah, see, I just wanted to mention, I didn't want to interrupt the conversation with Dr. Phillips, really, but I think if, anyway, what I wanted to mention is that, see, there is provision for elective placement in forensic. Like I had some elective placement last year. The year before, pre-COVID. So you can apply for elective placements in forensic psychiatry. And we do have students on the rotation visiting Rampton once during their placement, really psychiatry placement. So there is a rota for that, and there are opportunities. These are the two opportunities to get to see the forensic work and get to know how the secure system, secure hospitals work, really. So just wanted to mention that. Thanks.
Yeah, just on that topic, I don't know if it's still running during COVID, but yeah, the East Midlands has always had a for high school forensics elective program. I knew that existed when I was a student. I think Santosh knows better than me if it's still running now, but that was a way of nationally allowing students who may not necessarily be in a locality which has a high skill service to get access to that. I just have a quick question for Dr. Name while you've got her. I noticed that you also have a background in sports and exercise psychiatry. I just wondered if you wanted to just expand, just because our students may not necessarily know much about it. It's a niche part of psychiatry in its own right, but I think it'd be really interesting for people to hear about.
So sports and exercise psychiatry is really new. It's not an official specialty, and at the moment it's a Royal College special interest group. And there are two components. The one is an interest in exercise as a therapy. And we know that psychiatric patients have a higher mortality. There are often a lot of reasons why people get into inactivity, which can be just hopelessness, lack of confidence, isolation. So it can play a huge role. And at the moment, a lot of the organizations who get involved are charitable organizations, but we know it can really benefit us. We know that it does improve mood, it does improve those brain cells connecting. Now, my other interest is in athlete mental health, because there's an overrepresentation of athletes who get eating disorders. We know that a lot of the things that make someone really good at being an athlete also are factors which predispose to this illness. I've just completed a certificate in sports psychiatry from the US. And unfortunately, at the moment, most of the athlete clinical opportunities are private, but I'm going to be doing something sort of very part-time. The work is there, the need is there, the demand is there, but at the moment, it's all through athlete medical schemes. And there again are a fabulous bunch to work with, and it's really exciting. The Sports Psychiatry Special Interest Group, at some point we are going to be doing a Psych Start or Choose Psychiatry event for trainees. And I think thinking about lifestyle and exercise all as part of lifestyle is really, really important because of that connection between our mental and physical health. So also really exciting, really dynamic bunch of people. And hopefully we get that conference done soon. I've got a meeting with the Royal College trainee rep. And I guess just to add in, it's offered opportunities. I've been a chapter author. I'm making links with sports and exercise medicine as well. So really good fun. And I think that there'll be more of exercise and psychiatry in the future.
Perfect. Thank you so much, Ron. So it was piqued my interest when I saw that written in your biography. Just looking through, I just want to make sure we're not missing any questions here. I just want to check with Marie that we've got. I'm sure they're hovering out there in the community. One question I just kind of wanted to ask the panel as a whole. When you were, I know training was slightly different for you guys compared to us now, but when you guys were getting towards the end of your SHO training, looking towards becoming a road specific, was there another specialty that you guys could have done? What was swung it in one direction or the other?
I think for me, it's the people I worked with, actually. It was the inspiring leaders that I had the great opportunity to be core trainee, SHO and Old Money under, and they really gave me a direction, should I say, and I was toying with AMH, to be honest, and until I did my learning disability rotation, I wasn't really interested in going down that line. And I think this sort of raises an important point, actually, because I think this is applicable for the rest of psychiatry subspecialties as well, is if you seek information and understanding, a lot of the assumptions do get dispelled, because what I found particularly with this specialty is that students, when they do find out more, or they do have some more experience, or they do attend days, such as the specialty ones that we've been holding annually, the response is, I know quite often is, I did not know that this specialty was about this, and I just assumed it was like this. And I think that's really important, particularly as we're all jostling for time to get our specialty put out there at universities or other areas, giving the opportunities for shadowing, taster days, electives, all that just gives that extra, it just opens up avenues for people to see more information and just get rid of those assumptions that may already be pre-existing.
I'd sort of second that, and I do think kind of, looking back, it's a very long time ago, but looking back, it's the importance of role models, seeing people who are doing things and working in ways and, sort of living professional lives, that you would think you would quite like to follow on from, and that's really important to sort of think, because you're making a big choice when you decide what your career is going to do, and, and seeing something and thinking, yeah, I'd like to be doing that myself in 5 years or 10 years time. The other point is about sort of mentorship and kind of formal and informal mentorship. And I think all of us as speakers have said, we're available. Colleagues, senior colleagues are always available. And if you're interested in a field or in an area of professional activity, approach people, either people you've done a placement with or an elective with or a special study module with. Say, you're thinking about doing this, and, ask questions and be curious. I think all senior doctors, but especially psychiatrists, we love talking about, we're passionate about what we do, and we're really happy to talk to people who might be interested in doing the same thing.
Thank you very much. I think we're just going to make sure all connections a little bit stuff with that. But there was a question first of all, in the chat. There's been a note about the RC Psych psychotherapy faculty, which has both letters, conference dates, which is to be posted there. One thing I highly recommend is to any students to look through the Royal College website. There's a whole wealth of information about the subspecialties and the special interest groups. The medical student rates for conferences are generally very low, and allow you to, especially now a lot of things are virtual, it opens things up. It doesn't necessarily require the travel that things used to have in terms of attending events. So I highly recommend it. There's also a question generally for the panel, which came up from yesterday, which would be highly relevant. How do you find dealing with the risks and emotional impacts of difficult patients on you and your teams?
Well, I think Itai mentioned this morning that we are all leaders. Yeah, we are all in leadership positions as medics, and we have a responsibility. And often we sometimes underestimate how much power we actually have. People do look up to us. They do want guidance, and members of the multidisciplinary team will want to get your opinion and support. But it's just not about sort of knowledge sharing or information. It is really about ensuring that you are there to contain any of this kind of emotional upheaval that might happen. And it does happen. It will happen in all specialties, psychiatry or otherwise, that actually teams will get impacted. And we've seen this obviously over the last year with COVID and pandemic and people on the front line in ITUs, no doubt. But as a leader, you have to steer that ship and be there and be available and really try and make sure that the situation is contained, calmed, and just really be there. So we have a responsibility. That doesn't mean that you're necessarily isolated and that you're the only one doing that, because in my view, everyone in the team is a leader as well. However, by virtue of your experience and your training and your skills and all that side of things, you will have colleagues that will be coming to you and wanting that support. And it's important also that you yourself also have seek support should you need to discuss any particular issues that might be emotionally difficult as well. We all shouldn't shy away from the fact that if we do need help or extra support, we should be able to seek that out from other colleagues as well. So for me, it's very much about being a stable force, should I say, during difficult times. And to be honest with you, that is the challenge, but it's also the joy as well, doing that.
Dr. Phillips, I think you had your hand up.
Yes, just to add to that, really, I think through psychiatry training, you are very supported. I think that's often given as feedback that we supervise trainees regularly. They get a very good level of supervision. And as I mentioned, in my role as part of core training in psychiatry, you're part of a balance group, so you're improving your reflective capacity and your ability to manage your emotions through doing that, as well as through supervision. I think you need, through your career, whatever you go on to do, I think it's going to be very important for all of you to find ways to manage difficult feelings. There's not a field of medicine where you won't have difficult feelings. There are similar things to balance groups in general hospitals. There's something called Schwartz rounds. I think in Nottingham they used to run them. I'm not sure if they're running them at the moment. But I think we're all different, what helps us cope with difficult situations. But I think you need the more professional opportunities to reflect, be that in peer supervision with colleagues if you're a consultant, be that in your CPD appraisal group, be that in clinical supervision with your consultant, be that in Balint groups, be it informal chats in the kitchen, as long as it's confidential, over a cup of coffee with a work colleague. Don't underestimate how important those cups of coffee in your room with a fellow colleague offloading a bit are. They're just so important.
Thank you, Dr. Phillips. I think it is important to reflect on how much psychiatry is a team. And I definitely noticed when I did my foundation jobs in psychiatry how well supported I was by senior colleagues, not just SHOs, but also registrars and consultants. In terms of, so we've got a few minutes left, so we can ask a few more questions before we round off. I just wanted to kind of ask in terms of Scott, in terms of an academic career. You mentioned people who go into academia full time. Is there any advice you give to those who kind of want to add in academia as part of the clinical practice, but not the whole kind of career in the way that you've done it? Is there any good ways of going back? Do you suggest that that's something that someone starts at medical school and carries on with?
Yeah, definitely. You know, the earlier you start thinking about these things, the better. What I would say, though, is, you know, although there is such a thing as an academic, the academic foundation program exists, you're a clinician first. You know, you've got to decide where your clinical interests lie, and then the research questions and the research interests will follow. And the idea that somehow, you know, you'll be an academic and then maybe a clinic, it doesn't work that way. You know, whatever specialty, whatever bit of medicine you end up in, you know, you're a doctor first, and then you develop your research interest. Some people will be basic scientists and will have come into medicine. A small number of people will come into medicine after having done, you know, a degree or a kind of very research related field, and they'll already know, you know, that their interest is in sort of neuroscience or some sort of biochemistry. But there's a small number of people who will want to combine a medical career knowing that they're sort of basic scientists. But for the vast majority of us, you know, we go into medicine primarily as clinicians. And I think my advice would be, take advantage of any opportunities that come your way. So do the research modules, do the research placements as a student, the SSC placements on your course. When you qualify, make contact with your R&D department, you know, start finding out about the research that's going on around you. Be very interested in service evaluation and quality improvement and audit. Those all help you to develop critical kind of research skills. But above all, be a clinician first. You know, you're going to be a doctor, you're going to be a psychiatrist all of your career. The research bit comes alongside that and enhances it, and, you know, and benefits from your clinical skills. Your clinical skills add value to the research that you do, as well as the other way around.
Thank you for that. I think that's really important what you said about being a clinician first, and also just to kind of reassure all of the medical students here, there's a lot of anxiety around the academic foundation program and whether or not that marks you as an academic and whether or not you can have a career if you don't necessarily get onto it. And I think it's really important to say that it's not required, it's not necessary. It's a nice thing for those who are at that stage of their careers who want to do that. But there's plenty of academics who don't.
Yeah, no, the academic foundation program is a really weird bit of historical kind of archaeology that goes back to several attempts ago to rearrange medical careers around a run-through notion. And it's there, and it never got taken away, which is sort of helpful, but it doesn't mark you out. It's a good thing to do, but it doesn't either mark you out as going to necessarily have an academic career, and it not doing it doesn't exclude you. So don't worry about it. Apply for it if you want to. It's a good thing to do, but it neither makes or breaks your kind of career as a potential academic.
Sure. Thanks for the reassurance. Yeah, I think that reassurance is important, because I think one thing that definitely I felt as a student, there can be a lot of myths and mysteries, and part of the reason we do these events is to kind of show A, that there are options in careers, and B, that things aren't set in stone in year 5 or year 4 of medical school. So we're up to 12:30, which was the end of our session. Just looking if there's any last few questions to come through, or if Marie has received anything by email. That's why I just wanted to thank all our speakers for coming in today, for giving up their time and being willing to talk to everyone and kind of open up psychiatry as a specialty. It is a growing specialty. There will be, lots of opportunities going forward. I'm at the stage where I'm looking forward to starting my core training next year and finding out more in terms of what will come from there. I think in terms of wrapping up today, the kind of broad strokes that we can really identify is that leaping at opportunities when they come is the best thing you can do. The worst thing, as I think Itai and Dinesh said, the worst thing that you could, the worst thing you're going to get for anyone is, sorry, I don't have time. And that's all it's ever going to be. And honestly, my experience, I've never got that from a consultant psychiatrist. I've always been greeted with helpfulness and openness and willingness to engage with medical students, be that through a phone call or meeting or placement, or even when I was lucky enough that I went on elective before COVID and I was able to, off a bit of Googling and an email, arrange a placement in adolescent forensics. And that's the kind of range that you can get. We have one question, is how would you approach the care of patients who have multiple mental health issues? I think we can quickly answer that for those who can stick on. I know some of you will have to disappear. Thank you very much, Dr. Mudholker, for coming. If anyone wants to, I think it's in the context of those who would come under multiple specialties. Is there any particular answer that anyone wants to give in terms of managing that?
All right, I'll take that one. So multiple mental health issues. Like I said, we've before, we don't work in silos. We have to understand about what are the circumstances, be it medical, psychological, social, etc., that might be driving these particular difficulties. And this is why it's quite a complex speciality in that respect. And you are a detective. You're trying to unpick and understand what are the factors that may be contributing to this. But you're not working on your own. You are working with a multidisciplinary team, and having that access and skills to resource is really, really vital. It does vary across the country. Some teams are better resourced than others, and that is unfortunate. And I certainly do believe, and I think many will share the same view, that mental health does need a hell of a lot more funding than it's receiving right now. And there's also the question of actually the organisation of services as well. But we have to rely on collaboration, not just within our team, but also within external, to understand, if somebody's got such a complex disorder with lots of different layers. And mental illness is one of those things. We have a diagnostic system which has been there for a few decades, but ultimately it's there, in my view, as a guide. It's not there necessarily because we need to rigidly stick to that. Professor Bugler mentioned about medicine being an art. Absolutely is. We need to, and we have, it is one brain after all, and it gets influenced, by multiple factors, and we need to bear that in mind when we're thinking about whether somebody might be having a depression, an anxiety disorder, bipolar, ADHD, and often I do see people with a kind of long list of diagnoses, but ultimately it's not ensuring that we're not separating that person and just focusing on that on that kind of diagnostic list. Like I said, it is one brain, not rigidly sticking to a diagnostic system which is there to support and help, but ultimately we need to ensure that we're understanding that that is not the be all or end all, and things can be much more complex than we might take them for face value.
Thank you, Dustin, for that. I won't keep everyone very long. I'm sure lots of you guys have placements to rush off to. So just finally, a great big thank you again to all our guests for coming along and giving up their time today. And to finish off, just the same advice I give to every medical student at every event that we do is get involved with your local psych socs. Keep in touch with RC Trent in terms of what we're doing in terms of events. and to join the Royal College of Student Associate and look at things like the Psych Star bursaries, things like the Foundation Fellowships. There's lots of mentorship, funding and support available for those interested in career. Please do fill out feedback form. I'm sure if there's any questions that come through, we'll try and get them emailed through and answered back. And is there anything else I need to say, Marie?